Good afternoon, everyone. Welcome in. I'm super excited about the program we have today and this incredible speaker panel that has kindly volunteered their time to put this presentation together for you all, and really appreciate all the participants spending an hour or so here together with us. So just to give you a sense of what we're going to be covering today, we've got an introduction to SBIRT for those of you who are unfamiliar, or for those of you who are familiar with it. We're going to go more of a deep dive, and what's great is we have some of the original team that's been leading this work at King County and Seattle Children's, Dr. Cari McCarty and Margaret Soukup. Devyna, unfortunately, had an illness today, so she's last minute not going to be able to join, but we'll hear from them first for about 20 minutes. And then we'll do another session at about 1:30 with our team from Renton School District, who has been leading the implementation at Dimmitt Middle School in Renton School District. So we'll get a little bit of the background on SBIRT, some information about the evidence-based intervention and how it's been implemented across King County, and then we'll get a specific use case or example with what Renton has been doing over the last several months. Then we'll pull the group back together, open it up for questions and answers session. As always, feel free to drop questions into the chat as we move through the program. If something comes up for the speakers, we can kind of write it down and come back to it later in the session. Couple of quick housekeeping items and reminders. Closed captions are available. If you can click on the closed caption button to access. As speakers come online, we'll be muting everybody except the facilitator. When we open it up for Q&A, you can raise your hand or come off mute, or just drop questions into the chat. This event will be recorded and shared with participants through email after the event, as long as the presentation slides. So before I hand it off to Dr. McCarty and Margaret, just wanted to remind everybody about our first learning session, which was late last year, where we heard primarily from our Director of Student Services at Renton School District, Vicki Blakeney, who really put out a draft mission and vision statement of where Renton School District is planning to head in the coming years, and really focused on ensuring that every student and family can access the services they need to achieve social emotional well-being, regardless of social, economic, or cultural circumstances. And really the way that Renton School District sees to accomplish this goal is by working in partnership with communities, working collaboratively with cross-sector agencies to develop these student and family services. Now, what we're doing today is now bringing us a step forward. So putting that some action and movement around making progress towards that vision with this first strategy of implementing SBIRT. So hopefully that gives everybody the kind of orientation and coordinates for where we've been and where we're headed with this discussion. All right, so quick intros to our speakers. So background on Margaret Soukup. So Margaret is recently promoted to the Youth, Family, and Prevention Manager at King County in the Department of Community and Human Services in the Behavioral Health and Recovery Division. They oversee the continuum of behavioral health recovery, treatment, early intervention, prevention, and promotion. And Margaret, one of the programs she oversees is the SBIRT initiative, which is in approximately 60 middle and high schools across King County. And then Dr. Cari McCarty is a clinical psychologist by training and a research professor in pediatrics, and also an adjunct research professor of psychology at the University of Washington. She has been the program evaluation lead for the King County Best Starts for Kids SBIRT initiative, and conducts research and program evaluations to understand the interrelationships between alcohol and substance use disorders, mental health, and physical health throughout adolescence. So I will stop talking and hand it over to Margaret and Dr. McCarty.
Thank you, Adam. I really appreciate it. So I'm not going to have access to moving the slides forward. Is that correct?
Yeah, so just say next slide, and
okay.
Brian will move forward for us.
Okay.
And you can throw the spotlight on Margaret.
So at this time, I'm still in my role of managing the screening, brief intervention, and referral to services. And this project, I'm feeling a little distracted because the spotlight is on me, and that means I just see me. So I don't know if I like that. So anyway, so hi. So back in 2015, we received a very small grant through, thank you, Adam, I really appreciate that, because otherwise I'm looking at the slide and then me, and then I'm talking to myself. So back in 2015, we received a very small grant from the Hilton Foundation to potentially actually do SBIRT in the juvenile court system. And so I was told to shop it to the court. So I brought it to the court, and the judge said, we need to go upstream. And then he said, go talk to our truancy folks. And Scott will remember this because we actually talked about truancy quite a bit when we were talking about SBIRT at the beginning. And the truancy folks said, you need to go to the schools. So I went back to our funder at Portland State University, and I said, can we adapt this for the schools? And here we are several years later, and we're in 60 schools. So this started with 3 schools, and then it went to 12 schools. And then when we had this levy that was about to pass through Best Starts for Kids, our director said, can we take it to scale? So we were looking at all middle school schools across the county, and you all are one of 19 school districts across King County. So I was asked, can you build a budget to do SBIRT in 19 school districts? And so that's where we are today. It was a pitch, and we were asked to really figure out a way to respond early to young people, health promotion, substance use prevention in a large manner. And so the visual is really starting from 3 schools. Now we're in 60, and we're growing, and we continue to grow. So the context in which we are working today, and this is not anything that you all don't know. We know that there's a worsening mental health crisis for youth. It was there before the pandemic. The pandemic just really exacerbated it and made it worse. We've got increases in anxiety, depression, substance use, overdose, and suicide. Schools and other youth serving systems are stressed and stretched like never before. And what we are seeing in the data, but also anecdotally that we're hearing from the schools, is there's definitely there's been spikes in interpersonal violence, especially post-COVID, with young people coming back to school. And then we're in this place of attendance and school engagement is lower than it has been in the past. So our response to just really organizing a way of responding, it's a process. And many of you may have been SBIRTed in your own doctor's office. And SBIRT is it was created around substance use And so it's really like taking kind of a temperature check on really how much you may be using. And so you may be asked that in your doctor's office. And so what we've done around SBIRT, and some schools don't call it SBIRT, because this is really an adaptation of SBIRT to not just respond to alcohol use and other drugs, but also to respond to anxiety, depression, connections, to respond to what's going well, what are the protective factors in young people's lives. So it's really a more robust response to, really how young people are doing right here and right now. And so the SBIRT is the S is the screening, and we use a very specific self-directed screening called Check Yourself. And when we talk about universal screening, we don't talk about doing everyone at once. So we ask that the schools pick a target audience, which could be a grade. So let's say you pick one grade, and then you screen all of the 7th grade over a period of time. So that could be one classroom at a time. It could be a couple classrooms at a time. It really depends on what your capacity is. And then of those young people that are screened, then there are some that receive a brief intervention. Some schools, everyone receives a brief intervention. It's really just to check in. And other schools, because they're so big, they really only respond to the students that have some risk factors or have safety concerns. And so that is really a policy decision based upon the schools. And then of those folks that get a brief intervention, some get some type of referral. And that referral could be anything for further assessment to see if they need treatment. It could be organizational skills. It could be a mentoring program. It really depends on what that individual needs. How do we do the brief intervention, and how do we, doing that brief intervention and making that screening actionable? This is the opportunity. People often say, why don't we screen more than once? This is really an opportunity to connect. So the screening is really the beginning of a conversation. And for the adult to interact with that student around the information in the screen is really for that student to put what they said in context for the adult to understand. Because sometimes we just respond based upon, just a screen. So we've got a certain amount of information, and then without even having a conversation with the student, we make some assumptions, and we make maybe referrals based upon those assumptions. So the brief intervention is really to put what the responses were in context for that, with that student, really appreciating the whole student. It's really more multi-dimensional because we also want to know the strengths. What coping strategies do they already have? And what kind of supports do they have? And then also just when there are maybe some concerns or some symptoms, because this is not a diagnostic, it's really just identifying some symptoms that may be an issue, putting those symptoms in context of their goals. So maybe how these symptoms might get in the way. Let's say their goal is to be in the play and they've got anxiety. And so to have that conversation of, maybe how does anxiety fit in with the fact that they want to audition for a play? Really just asking the student really what they already know before we pummel them with all the great advice that we have, and really bringing in that cultural humility and the family along the way. So the screen, what is the screen? And it was created out of Seattle Children's Hospital called Check Yourself. And we have adapted Check Yourself with a lot of input from professionals, students, families, and we have evolved the screen. So it's kind of a screen and it's a survey. The screens that are embedded are validated tools like the PHQ, the GAD, and so they, screening for anxiety and depression. And then there's some survey questions as well around connections. So it's both a screen and it's also a survey. So this is something that it would look like. So the screen itself comes in, it's web-based, it's on a platform. And so a student gets a link. And that link is specific for that particular student. And it's not an ID that can be identified. And the only people that can identify that ID are the support team on the ground in the school. So this is what the first screen would look like, what to expect. And I can tell you right now, we've just translated this into additional languages. So it's in English, Vietnamese, and Spanish right now. And then as of next week, I think it's translated into Chinese, Simple Chinese, Marshallese, Russian, Ukrainian, and then we're actually growing to other languages as well. And I want to just say with this, the entire thing is voluntary. So parents can opt you out. So a parent can opt you out even before the student takes it, and then the student can opt themselves out. It's pretty remarkable how many do not opt out and want to take the screen. But again, it is voluntary, and this is something that I want to make sure that everyone knows. So these are the different components in the screen, and the student can decide which one to start with. Also, the key components of the screen, not only are they going to take the screen, but they're also going to get some feedback based upon what they say and what their age is. So some of the feedback is educational, some of the feedback that everybody gets. Some of the feedback is based upon what they say, like I'm sleeping only 4 hours a night. And so the feedback would be, at your age, you should be sleeping X amount of hours per night. Risks and benefits, and then there's some tips for behavior change. So if there's no concerns, no risks, the student would get some feedback around how, just really responding, positive reinforcement around the healthy choices that they're making. And that was actually a change because our students asked for that. They're like, well, I'm doing everything right. Why aren't we getting some, positive feedback? So that really came from students. So why are we doing this universal screening? Well, there's a lot of reasons. One is what we're hearing a lot from the schools, and we're in over 60 schools, is this is a response. It's more of a response than a reaction. So screening everyone, you're responding to them in real time, and you're not waiting for an emergency to arise. We're also not reacting only to externalizing behaviors or a crisis, because there's a lot of our students that are internalizers, and they look really well on the outside, and they've got some quiet distress going on. And out of the 25,000 students as of last year, around 5,000 students identified were students that nobody knew were suffering. The principal didn't know, the attendance lady didn't know, the teachers didn't know, the counselors didn't know, because the student looked like they were doing well. But then when they took the screen, they said that they were suicidal. And that was something that I think kind of blew everyone away, with how many of our young people are not telling us what's going on. So the other thing that we're hearing too, and I don't know if Renton will be talking about this, is we're hearing that job satisfaction is going up for the counselors and the prevention folks and whoever the adults are that are responding. They feel like they're finally doing the job that they were hired to do, because they actually get to connect with kids, and more kids than just the ones that are acting, having externalizing behaviors. The time it takes is about an average of 20 minutes. It really depends. Some of the students want to read every detail of that feedback. Others skip right through it. So it really depends on what they want to do. The sorting takes about 45 minutes on average. That's identifying students, and then who they're going to be assigned to for staff, and any kind of notes or background. So we also align with the multi-tiered systems of support. So we say tier 1 would be what everyone gets. So that would be everyone got the screen, and maybe there's no concerns. So that's up to the school whether or not they respond. Some just respond, have a real light touch, like how was that for you? Not asking any details, but just checking in on how was that. Tier 2, there's some kind of symptomology, not a safety issue, so you could set up an appointment. And that usually happens within 2 weeks. And then we've got tier 3, and those are the safety concerns: self-harm, suicide ideation, and bullying with a current safety risk. So you'll be asked about bullying. If you say yes, and then if you feel unsafe right now, that's worth an immediate follow-up. So the protocol is to follow up within 24 hours. Most of our schools are following up before the end of the school day to check in and put that information in context. So you could see kind of how we've organized this around that multi-tiered systems of support. Really, that foundation is what Renton has done now, is really building that foundation of communication, support, communicating with families and the students and the teachers. And that tier 1 is really that universal screening. And if there's no risk identified, how you're going to respond. If it's going to be a postcard, is it going to be a meeting? That's really up to the school. Tier 2, again, that just, there's some risks, and that's worth a follow-up within 2 weeks. And then tier 3 is an immediate follow-up, likely before the end of the school day and within 24 hours as a protocol. The brief intervention is based upon motivational interviewing. It's really, so a lot of our training is in motivational interviewing, really being in partnership with a young person, accepting them for who they are, really bringing in that compassion, and then that really focusing on their autonomy and their own empowerment. These are the elements of the brief intervention. You do not need to have a master's degree in mental health to do these brief interventions. It is really around getting trained well in having a conversation with the student in partnership, that we are in conversation with, and we are not doing to the student. So there are elements to that. You may only go through one, which is checking in on the screen, and that's the only conversation. You may have multiple conversations. It really depends on what that student needs. And the referral to, not all kids get the referral to. About 15% of our population receives some type of a referral. And again, that can be to multiple things. These are some of the things that we look at as a resource: housing, financial, could be treatment. A lot of our middle schoolers, believe it or not, need organizational skills and tutoring. A lot of them have gone to, multiple classrooms all of a sudden, and they used to only be in one. And the anxiety that's coming from that is really around this new environment. So it's not clinical necessarily, but it's real, and they do need a response. And the fact that we can respond early before our students get really sick is something that we're noticing, and the students are noticing, and they're feeling like people are seeing them and following up with them and caring about them. So what happened? And this is when I'm going to pass it off to Dr. McCarty with all of our data.
Yes, thank you, Margaret. As Margaret said, this program has been going on. Actually, we're in year 5 now. We don't have the numbers fully on year 5, but I can give you a preview. Year 1 was kind of a pilot. Year 2 was full implementation. Year 3 was COVID, where we pivoted and did as much as we could remotely, but it was a smaller year. And then year 4 was sort of back to normal. And so far in these 4 years, over 25,000 were screened. And we already know that this year we have about 10,000 more who've been screened, most of which are middle schoolers. About 80% of year 5 is middle schoolers, and then the rest is high schoolers. So now we're looking at data across all the schools that participated for years 1 through 4, and we can see the racial and ethnic distribution of participants is pretty similar to what we've seen in King County schools. And then in terms of gender representation, we have about half students identifying as male, 46% female, and then we have about 4% who are indicating that they're non-binary, transgender, or something else might fit better. So this is a lot of data here on what kind of risk factors were endorsed by the students during the screening process. And we've organized these data in terms of some of the indicators that generate a red flag, which means that those are students that we want to see within 1 day, ideally. So students, about 7% indicating suicidal ideation, and 9% indicating thoughts of self-harm. Anxiety was about 18%, that's that bar, and then depression was 15%. And 17% is bullying without an imminent risk. The students who indicated an imminent risk for bullying was the 2.9%, which is in red. And then in terms of middle schoolers, we see pretty low rates of substance use. You can see about 2 to 4% indicating some use, but we see higher rates of intention to use. So we do encourage, the program encourages conversations between the interventionists with students when they indicate that they're thinking about using, so that it can be a preventive intervention as well. So we also did surveys for students who participated in the SBIRT program to ask them about their experience, so we could understand how they felt the intervention went and what it was like for them. So these are how they rated the interventionists, and you can see about 93% of students felt their interactions were good, very good, or excellent across all categories. So those would be the light green, the light blue, and the dark blue. And then the one on the left, that's about 8%, that means that they indicated fair. So most students felt that the interventionist did a good job explaining why they're meeting, and they felt really comfortable during the intervention. As you can see, only 4% said fair on feeling comfortable, which is pretty surprising for middle schoolers, because this can be an uncomfortable process, but the interventionist did a really good job of having the students tell their story and listening to the student as a whole person to try to understand what's going on in their life, not just diagnostic, but really like a big picture scenario. The other thing that we did assessments on to look at change over time was how connected students felt to the adults at school. And school connectedness is a really important resilience factor for a number of important outcomes in adolescence. And we basically saw that there was a high change in connection to adults after participating in SBIRT. So this is based on 389 students. And at the beginning, 58% said, yes, there's an adult who listens to me. After they had done the SBIRT process, that number jumped to 71%. And we saw similar changes in other indicators of school connectedness. There's an adult at school who cares about me. There's an adult at school who believes in me and who tells me when I do a good job. And as you can see with that, yes, also the percentage of students who are saying, no, I don't have that adult in my life is going down quite a bit. So it's really a pretty small percentage, less than 10%, after they've completed the SBIRT process. So this evaluation data has actually been published in the Journal of Adolescent Health, and there's been a lot of interest in it as well.
Thank you, Dr. McCarty, and thank you, Margaret. Yeah, really, really helpful to get a kind of a detailed view of the background in the program and how it's been rolled out into the schools. And I think what was most exciting for me to hear was about some of those ancillary benefits of screening that we don't often think of with a screening exam. So really helpful to see the data. We're going to switch now from kind of more of a global view of the SBIRT program to the specific work that's been going on with Renton implementing this program. So I'm going to turn it over to Devyna Aguon, who is a social and emotional learning facilitator at Renton School District. I think many of you know her well. And then we also have Scott Sturdivan, who is a school counselor at Dimmitt Middle School and has been working to implement the Dimmitt or the SBIRT program. So I will turn it over to you, Devyna.
Thank you, Adam. So why SBIRT? Why did we commit to that? So one of the things that you probably already know in working a lot with our community providers is that our district is really trying to work intentionally at supporting the emotional and social needs of our students. And to do that, we need to know where they're at socially and emotionally. And so the Check Yourself screener that was explained earlier through SBIRT has demonstrated in other districts to be effective in doing just that. And so one of the reasons before committing to the program, I want to go a little bit back about why we chose Dimmitt. Before committing to the program, we wanted to look at the supports and partnerships available in our community across our district at our different schools to ensure that we would be able to connect the students with identified needs to appropriate supports. And so we worked on our community map, and Dimmitt was identified as one of our schools with various types of partnerships from tier 1 to tier 3. And in addition to that, our Dimmitt counselors were also doing intentional work in trying to look at how they identify their students and trying to develop any small groups to support their needs. As such, we reached out to their team to explore their interests, and it was an immediate yes. And part of it is because Scott has done previous work with SBIRT. And so, of course, we decided to commit to the SBIRT program. And I'd really like to introduce you to one of those counselors, Scott, who will share more about our pilot at Dimmitt.
Thanks, Devyna. We talked about how we could, how we were going to select where in the school to implement the SBIRT. And so for that pilot, we selected one of our AVID classes, and that's because it gave us, it offered us a cross section of the students at our school and the population that we had. And we also knew that our teacher in that class is committed to social emotional learning and health. So it would be an easier sell and easy to work with her. Our administration was also pretty on board because we had already talked about universal screening process, just the idea of that being important. And so in implementing, we chose, I think we talked about earlier, the opt-out permission, like Margaret had said earlier, and only one chose to opt out for both of the classes. So we implemented it over 2 different class periods throughout 2 different trimesters. And in order to implement that, our teacher, she was a previous ELL teacher, and so she understood the importance of vocabulary. And so we looked through the screening ahead of time and picked out some vocab words that might be challenging for some students, or might need just some explanation. And so she put together a presentation for her classes, going over some of that vocab, allowing the students to come up with their own definitions, and then clarifying those as they went along. When we went in to do the screening, all students ahead of time were told that a counselor was going to meet with them no matter what their responses were. So I kind of normalized the process, and it wasn't, I think it was helpful because nobody felt like they were called out for anything specific. And even just in speaking to the students who weren't necessarily a tier 2 or 3, we were still able to learn a lot from those students. And if they had a lot of positive coping skills, then we could encourage them to continue those things. Other times, some of our students who were like in the green area, actually in having a human connection and talking to them after the screening, they actually gave us more information than they put on the screening. And so, so I think we were able to get that from students in a way that maybe the screening didn't capture. It wasn't that many students, but we did get some of that information through that in that way. Students generally thought it was pretty easy to do. It was pretty quick. I think something that goes to show how kind of seamless the screening is that one student said that it felt like they were reading her mind because of the way that the questions were responsive and how she answered. And I think also from that screening and as we were meeting with the students afterwards, going back to something else that Margaret had said, that quiet distress, it forced me to kind of check my assumptions, because when I looked at the two classes, I had already put an assumption onto which class was probably going to read higher in tier 2 and 3. And in fact, it was the opposite. Because of that, I think quiet distress. The one class was typically more of the students that we see as stable and higher performing. There was more of those in that class. And so it was opposite of what my assumptions were, which I think was, it's a good reminder, and also something that we were just able to see through the screening. So some of the population that the level data that we had, it was just 39 students. It was over 2 classes, and there were 9 students that came up as tier 2 or tier 3 students. The priority needs that they mentioned, I think it's, if you work in schools, I think it's pretty common, especially now, to know that anxiety is going to be one of the higher things that we notice and see. And then the other one was bullying. And I think in meeting with all of the students, we were able to help students recognize bullying versus something else, because we know bullying gets thrown around a lot as a word. And so that was helpful, just to be able to educate students on what that actually meant and maybe change some of their perspectives, and help them with that coping skills, whether it was just like a student being mean, or whether it was a full like bullying situation. And then the number of students that we referred to support services. So out of 39 students that we screened, 11 were referred, and that was to both outside services that we have that come into the school, and then in-school intervention groups. So we were able to look at the data of what the highest needs were. Anxiety, actually, as I just mentioned, was higher, and so we implemented at that point with this group of students coping skills, coping strategies, and goal setting group for those that came out of the screening. Student stories, I think I mentioned a lot of those kind of on the previous slide. Yeah, yeah, I'm not sure actually. I think I told all of my stories that I had prepared for that. And then I think what worked well, and maybe not so well, going back to meeting with all students, what we found was that they felt more connected to us. We had a pretty good group of staff that were willing to be a part of it, which was helpful, because we had a team that was here to support us. The three counselors here, we all checked in with the students and committed to doing that. And it went really quickly. We weren't sure how it was going to go and how much time it was going to take up. But because of the support that we had, we were able to move through it pretty quickly. We saw all of the tier 2 and 3s the day of the screening. And then the greens or the tier 1s we saw that week after the screening. Other things that worked well, I think I said so earlier, we used the data. We were able to use the data to implement some school-based intervention groups there. And as far as what didn't maybe work so well is, I was talking to Adam and Devyna about this yesterday. I think it's more about things that would be challenges if we didn't have the support. And so that would be like the time involved in addressing the needs or meeting with the students if we didn't have that team support. And then the other thing that is just a challenge that we all know is that there are not available resources for everything that we need and for all of the students. The resources are there, but we know that there's a long waiting lists, or sometimes resources that aren't necessarily a good fit or culturally appropriate. And so that's a challenge that I think we all have experienced if we're working in the schools and know that. So I know that we are going to be doing work on that. And I think that is Devyna's going to share some of that.
So we did complete the screening for this school year, 2022-23. at Dimmitt. We have been very, very fortunate to have secured an SBIRT grant from King County to expand this work for the next 2 school years, and we will be expanding that at McKnight Middle School, Nelson Middle School, as well as Risden Middle School. And our goals for expanding that will include, at least for Dimmitt Middle School, it will include screening all 7th graders by spring 2024. So by the end of the school year, we will screen all 7th graders, and we will start that work in the fall of next school year. In addition to that, we are hoping to expand, like I mentioned, to the other 3 schools. And by the end of that school year, so by the end of spring 2024, we are going to screen at least 1 class at each school. And we were going to be doing that just as we did with the pilot at Dimmitt. We'll start with 1 class and then increase depending on the capacity. Another goal is to be able to screen 1 entire grade level at each middle school by the end of spring 2025. So that's what we're hoping for the next 2 years when we're looking at the expansion of SBIRT. And in order to successfully expand SBIRT, we will need to address some of the current challenges that Scott had mentioned related to referral to treatment. Luckily, currently our district is contracting with Talkspace to provide telehealth. However, that is being funded with through ESSER funding, and so it's giving us some time to work with our community providers and how we're addressing this. Because we all know the current process for matching and connecting students to community mental health providers, there's some barriers in accessing and coordinating those services. For example, school counselors call the different agencies right now to inquire about their wait list for when students would be assigned a therapist. They're also spending a lot of time on follow-ups with their referrals to see if the referrals were received, if they were assigned a therapist, or if services are being accessed. And so this really limits their capacity to be able to serve in other areas in their job duties, as well as meet with the other kids to make those connections. And then also school counselors don't always get the feedback if a student engages in services or what their care plan is moving forward. And so really looking at trying to coordinate those services. So the thing is, if we expand screening and identifying more kids with needs, they're going to struggle with the workload of coordinating that support services and making sure our students get access to those services. And so to solve for this, we put together a work group that includes school counselors as well as community providers. And for the last several months, we've been working together to design a solution to this problem. And I'm really excited to share more about this. Unfortunately, we are going to be sharing more about this at our next Learning Network session. So please stay tuned, and we hope that you can join us. So we wanted to be able to answer some of the questions that you may have.
Thanks, Devyna, and great job leaving a suspenseful cliffhanger for our audience to return for our final Learning Network event next or in the coming months. I see some great questions from, I think it's Zaza in the chat. Hopefully I'm pronouncing your name right. Zaza, are you able to come off mute and ask those questions? If not, I can, but we'd love to hear from you.
Can you hear me? You
bet.
Okay, awesome. Sorry, my computer kind of froze a little bit as you asked that. Hi everyone, I'm Jaja Power. I work with ACRS. I'm one of the clinical supervisors in the Children's Mental Health Department. I have a couple of questions. So one being is that I know back in 2015 when I used to work in a school district, there was this big thing about PBIS. I think it was like positive behavior intervention, and I forgot what the S is. I think it's supports. Is there a difference between SBIRT and PBIS, or is SBIRT kind of like the expansion version of PBIS? Because they sound so similar, but I know that different acronyms get kind of thrown around and different ways of doing things also get thrown around. So I would like to know if there is some type of difference between the two.
It's a great question. I can start and feel free to jump in others, but I think that PBIS is kind of an umbrella framework for thinking about how we can create structures within schools for positive behavioral intervention. And I think SBIRT is one mechanism that can fit within the PBIS framework actually as an intervention. The thing about SBIRT is it really helps to help the student themselves identify what their needs are. And a lot of times with PBIS, it might be based on things like the existence of an IEP or a 504 plan or a teacher referral. So things that other people are saying, oh, this student needs support because of this. With SBIRT, we're learning from students themselves. And a lot of times the students who we might not think need support, you know, some of them are doing quite well academically, but we're learning that they actually do have other mental health or other needs that aren't being seen without the SBIRT process, without that screening. So when we conduct the screening part of SBIRT and the brief intervention, we learn more about the students and what they need, and then we can think about similarities in terms of triaging those levels of need. And again, somebody might be doing very well academically, but they might have some needs that are sort of quietly simmering on the mental health front.
Yeah, and I think, the language obviously is very similar, Jaja. Like we've got the tiers, and the tiers mean pretty much the same thing when we talk about PBIS and SBIRT. Like Dr. McCarty said, I think SBIRT is one of those interventions. And in that way, we do PBIS. We think of it as like here's the green or the tier 1 is things that everybody gets. And a lot of times those students who have that, maybe that quiet distress, we put in that tier 1 category of things that they all get. And so we're not necessarily capturing those students in like the tiers of PBIS. And so I do think it's important, like Dr. McCarty is saying, is that we are hearing from the students, because a lot of times in PBIS, we all come together as a group of adults. And here's our list of students, and this is what we think their problems are. And here we are hearing from the students, which gives that level of empowerment. And it's not only them telling us what their needs are, but them telling us what they already have. And I think that's really I've noticed that that's helpful for them to be asked these questions and then to have words for the things that they already have in a way that they maybe didn't have a way to say that before.
Awesome, thank you. I do appreciate that, because if I recall, like PBIS was more of like, what is the type of environment that you're trying to set within like that school, right? And I do appreciate that this is very student-centered, and that you're encouraging, advocating, and empowerment for like the students. I guess on that note, I did put another question in the chat, and maybe this is a question more for Margaret, because I know a lot of the examples have been more of like middle school examples. What does SBIRT look like for high school youth, and have there been any challenges that you've seen or like just like have encountered?
Well, we are brand new in high school, so we did our pilot last year. We have like a high school learning collaborative across all the districts to talk about these very things, you know, that come up. And we have a more robust like substance use screen for the high schoolers. We've added healthy relationships to the screen, and then also around disordered eating. So it's just high school kids are more complex. They have more, what we've seen, and we'll see how our data, you know, plays out this summer when we look at it, because we're in 16 high schools this year. So this will be the first time that we do that analysis. What we did notice, and we'll see if we had smaller numbers, I think it was around 600 high school students. It looked like, you know, the pie, if you remember it, the green was kind of, you know, it's typically, it's usually around half of the students like are the, you know, no concerns, so to speak. And then about, I don't know, about the other 50%, I would say we have about 15% that are like tier 3, and then the rest are tier 2. And that's been kind of kind of the balance for middle schoolers. What we noticed was that tier 2 got a little wider for the high schoolers. So the tier 3 wasn't necessarily more of the safety concerns, but we definitely had more of the symptomology. And so our green pie was not 50%, was more like 35 or 40, if that makes sense. So so with our pilot, we just saw a little bit more of anxiety, depression, things like that, which makes sense in high school, right?
Right.
But again, this is also post-COVID. So we'll learn more. We will be cleaning the data this summer, and every fall we do an SBIRT Institute, and we put all of the data back out to everyone so you all can see it. So
Awesome. Yeah, I would be interested to kind of like see what you all ended up learning and observing from just this pilot study. Thank you.
Great questions, Jaja. Thank you so much. I know we've just got a few minutes left, so I'm gonna go ahead and try and wrap us up. But Margaret and Dr. McCarty, hearing about that high school work, I'm thinking we might have the opportunity to bring you all back next year once you have that summer data, so we can learn about the implementation of SBIRT in high school. It'd be really great to get that update for the network here. Awesome. Well, thank you all so much for attending today's session. We are going to pop a link in the chat to a post-event survey. We're still getting used to how to put these sessions on, and so the more feedback we get from you all who attended the session about, hey, what are the topics you'd like to hear about? What went well in the session, what didn't go so well. We can get better and make sure these events are engaging and delivering the right information for you. As Devyna said, with that great cliffhanger, we will be putting on one more event here in the next couple of months. And we'll be sharing out some of the great work that the work group team has been doing to really dive into the complexity around care coordination between schools and community providers, and some ideas about how we might be able to solve from that. So hopefully you'll be able to enjoy that or join us for that. And with that, have a great rest of your afternoon. Thank you so much.
Thank you, Adam.
Thank you, everyone.
thanks so much.